I want to tell you about the first time I ever got asked to build a differential diagnosis in front of a preceptor. I was in NP school, early clinical rotations. I had studied. I had done the reading. I had looked at the practice AANP questions. I felt prepared. My preceptor was a seasoned FNP who had been practicing for 15 years and had exactly 0 patience for students who showed up without thinking. And on this particular morning, he sat me down in front of a patient's chart. A 52-year-old woman presenting with fatigue, diffuse joint pain, and a low-grade intermittent fever. And he said, "Okay, walk me through your differential." And I froze, not because I didn't know diseases. I knew plenty of diseases. I had studied rheumatoid arthritis. I knew about lupus. I had reviewed fibromyalgia. I had read about hypothyroidism. I had all these individual diagnoses sitting in my brain in separate compartments, like files in a drawer. The problem was, I had no framework for deciding which drawer to open first. I had no process for building a differential from the ground up. I had a list. I did not have a method. So I started listing rheumatoid arthritis, maybe, lupus, possibly, fibromyalgia, sure, why not? Hypothyroidism, fatigue is a symptom of hypothyroidism, so my preceptor let me go for about 30 seconds, and then he held up one hand, stopped me mid-list, and he said something I have never forgotten. He said, "You're not building a differential, you're guessing out loud." And he was right, because a list of diseases is not a differential diagnosis. A differential diagnosis is a structured, logic-driven, mechanism-based process that starts with the clinical data and works systematically toward the most likely explanation, while keeping the most dangerous explanations in view at all times. It is not a recall exercise. It is a reasoning exercise, and nobody had ever taught me the difference. That moment in clinical changed how I study. It changed how I teach, and it is the reason this episode exists, because here is what I know about you right now. If you are in NP school, or you are studying for your AANP or ANCC boards, you have a list problem. Your program taught you diseases. It taught you presentations. It may have taught you to memorize the top 3 differentials for common chief complaints, but it almost certainly did not teach you the cognitive architecture of differential building, the actual mental process that experienced providers use to generate a differential from scratch, from any chief complaint in any clinical context. And the boards test the process, not the list. Today we fix that. Welcome to Think Like a Provider. I'm Jenna Way, nurse practitioner, double board certified clinical educator and creator of Think Like a Provider, the clinical reasoning system that teaches nurses and nursing students to master body systems through pathophysiology and evidence-based frameworks. We don't memorize here. We understand. If you're new, every episode, we break down the mechanisms behind clinical reasoning, neuroscience, and what it actually takes to perform at your best, so you walk away thinking and acting like the provider you are meant to be. And if you want to go deeper than a podcast can take you, we have the Think Like a Provider Academy waiting list for school. Within it, you have access to high-yield courses, question banks, case studies, and a community of students who are done memorizing and ready to actually understand. The link is always in the show notes. Now, let's get into it. Welcome to the NP track. This is a dedicated space in the Think Like a Provider podcast for nurse practitioner students, NP residents, and anyone preparing for AANP or ANCC boards. Every single episode in this track does 2 things simultaneously. It teaches you the mechanism-based clinical reasoning that makes you a better provider in practice, and it maps directly to how both boards test that reasoning. So you are never just learning content in isolation. You are learning content the way the exam will require you to apply it, starting today with the foundation that everything else in NP practice is built on. Why your differential is probably broken. Let me ask you something honest. When a patient presents with chest pain, what do you do? If your answer is anything like, "I think ACS first because chest pain equals ACS," or "I run through a checklist of cardiac, pulmonary, GI, and musculoskeletal causes," or "I Google chest pain differential and see what comes up," then your differential is broken. Not because you're wrong about the content, but because you're using a method that will fail you the moment the presentation is atypical, the moment you're under time pressure, or the moment the AANP gives you a STEM where the obvious answer is a trap. Here's the problem with how most NP students learn differential diagnosis. We learn it by condition. We learn what chest pain differentials are. We learn what headache differentials are. We learn what dyspnea differentials are. We build a mental index card for each chief complaint. And then we recall the card when we encounter the complaint. And that works, right up until it doesn't. It doesn't work when the presentation doesn't match your card. It doesn't work when the patient has 3 symptoms that span 3 different complaint categories. It doesn't work when the board gives you a scenario where the most obvious diagnosis is ruled out in the second sentence of the STEM, and you have to pivot. It doesn't work when you're 6 hours into a clinical shift and your recall is slower than usual. It doesn't work when you are in front of a real patient who is not cooperating with your mental index card, because real patients are not organized by chief complaint. What works is a framework, a repeatable, mechanistic, 4-step cognitive process that generates a differential from first principles every time, regardless of the chief complaint, regardless of your fatigue level, and regardless of whether the presentation fits the textbook. And here is the research behind why this matters more than you might think. A scoping review published in the Journal of Advanced Nursing in 2022, and I'm talking about Smith, Benbenek, Bakker, and Bockwald, found that diagnostic reasoning is an essential competency for safe, independent NP practice, but that NP education programs vary enormously in how explicitly they teach it. Some programs teach it well. Many don't teach it at all beyond surface-level exposure. And the downstream consequence is what the data on diagnostic error shows us. An estimated 1 in 20 patients seen in outpatient settings experiences a diagnostic error annually, and cognitive factors including anchoring, premature closure, and availability bias are present in the majority of those errors. You are about to become an independent provider. You are the diagnostician now. The quality of your differential is the quality of your patient's outcomes. That is not an abstraction. That is the literal clinical reality you are stepping into. So let's build the framework. The 4-step differential framework. This is the core of the episode. Everything before this was setup. Everything after this is application. These 4 steps are what you are going to carry out of this episode and into every clinical encounter and every board question for the rest of your career. Step 1. Anatomy first. Before you think about diagnoses, think about anatomy. What is in the location of the symptom? What structures occupy that space or could refer pain or dysfunction to that space? When a patient says, "I have chest pain," your first cognitive move is not to think of diseases. It is to think of structures. What is in the chest? Heart and great vessels. Lungs and pleura. Esophagus. Stomach if there's referred pain from the upper abdomen. The chest wall itself, muscles, ribs, cartilage, nerves, the diaphragm, the mediastinum, the thymus, the lymph nodes, the thoracic spine. Every one of those structures can produce chest pain by some mechanism. And if you start with anatomy, you don't miss anything. You generate a complete structural map before you start filtering. This step takes about 10 seconds. You are not writing anything down. You are orienting your brain to the territory. You are saying, here are the players. Now I will figure out which one is causing the problem. Step 2, the mechanism filter. For each anatomical structure on your list, apply the vitamin C mnemonic. Not as a memorization tool, but as a mechanism checklist. Vascular, infectious, traumatic, autoimmune, metabolic, idiopathic or iatrogenic, neoplastic, congenital. Every one of those categories represents a class of pathological process that can affect any structure in the body. So you take your anatomical structure, say the heart, and you ask, what vascular processes affect the heart? Ischemia, infarction, vasospasm. What infectious processes affect the heart? Myocarditis, pericarditis, endocarditis. What autoimmune processes? Rheumatic heart disease, lupus myocarditis. What metabolic processes? Electrolyte-induced dysrhythmias. What neoplastic? Primary cardiac tumors are rare, but metastatic disease exists. You do this for each structure, and suddenly your differential is not a list someone told you. It is a logical product of anatomy combined with mechanism. It is derived, not recalled. Now, you are not going to fully work through every structure times every mechanism for every patient. You don't have time for that, and you don't need to. What you are doing is training your brain to think this way so that when you encounter a new presentation, you have an automatic, reliable scaffold to hang the clinical data on. The framework is the foundation. With practice, it becomes fast. Step 3, the probability layer. This is where the clinical data enters the picture. You have your anatomical structures, you have your mechanism categories. Now you apply the information you actually have about this specific patient to weight the probabilities. What does probability depend on? Base rates. How common is each diagnosis in the population you are seeing? Risk factors. What specific features of this patient increase or decrease the likelihood of each diagnosis? The clinical presentation itself. Onset, duration, quality, associated symptoms, what makes it better or worse, what the physical exam shows. And the epidemiological context, age, sex, family history, occupation, exposures. This is where the pattern recognition from episode 7 starts to earn its value. When you have enough clinical experience, the probability layer becomes faster because you have seen the patterns before. But even without experience, the framework gives you a logical structure to apply whatever information you do have. A 52-year-old woman with diffuse joint pain, fatigue, and intermittent low-grade fever. Female, reproductive age or perimenopausal, symmetric joint involvement, systemic symptoms. The probability layer pushes autoimmune processes, specifically SLE and RA, toward the top of the list. Not because fatigue plus joint pain equals autoimmune, but because the combination of features, the demographics, and the multi-system involvement pattern are mechanistically consistent with an autoimmune disease process. Step 4, the can't miss filter. And this is the one that separates experienced clinical thinking from novice clinical thinking. Before you land on your working diagnosis and plan your workup, you ask one more question. What on my differential, if I miss it, could kill or seriously harm this patient? That diagnosis, regardless of its probability, stays on the list until you have explicitly ruled it out. Not implied it's unlikely, not assumed it's not present. Explicitly ruled it out with the appropriate clinical or diagnostic data. Chest pain in a 45-year-old male with 2 risk factors for CAD. ACS stays on your list until serial troponins, ECG, and clinical response tell you otherwise. Not because ACS is the most likely diagnosis, but because missing ACS is catastrophic and irreversible. This is the antidote to premature closure, the single most common cognitive error in clinical diagnosis. Premature closure is accepting a diagnosis before you have fully excluded the alternatives that matter most. The can't miss filter structurally forces you to hold the dangerous diagnoses in view until the data clears them. 4 steps: anatomy, mechanism, probability, can't miss. That is your differential diagnosis framework. Every board question, every clinical encounter, every time. The AANP call-out. Let's talk about how the AANP tests differential reasoning, because knowing the framework is one thing, and recognizing it in board question format is another. The AANP Diagnose domain is domain 2, and after the 2024 blueprint change, it remains one of the 3 most heavily weighted domains on your exam, alongside the newly expanded Assess domain. The AANP does not ask you to recite differentials. It tests your ability to synthesize clinical data toward a prioritized diagnosis, and the way it does that has very specific patterns you need to recognize. Pattern 1, the most likely question. The AANP gives you a clinical scenario: age, sex, chief complaint, relevant history, exam findings, maybe a lab or 2, and asks, which of the following is the most likely diagnosis? The 4 answer options will all be clinically reasonable. That is by design. The AANP is testing whether you can distinguish between conditions that share features but differ by mechanism. The way you answer this question is not by process of elimination. The way you answer it is by asking which of these diagnoses best explains all of the clinical data in the STEM. Not most of it, all of it, because the AANP puts the distinguishing feature in the STEM. The single piece of information that differentiates the correct answer from the three plausible distractors is always there. Your job is to identify what that feature is and understand why it matters mechanistically. Example, a 28-year-old woman presents with fatigue, arthralgias, a facial rash, worse with sun exposure, and oral ulcers. Which of the following is the most likely diagnosis? Rheumatoid arthritis is on the list. Lupus is on the list. Dermatomyositis is on the list. Psoriatic arthritis is on the list. So, what makes SLE the right answer here, and not RA? Two things: the malar rash that flares with sun exposure and the oral ulcers. And here's why those two findings matter. Mechanistically, the malar rash in SLE is a type 3 hypersensitivity reaction. Immune complexes deposit in the dermal vessels, and UV radiation triggers the inflammatory cascade. That's why it's photosensitive. That's why it's in that specific butterfly distribution across the cheeks and nose. RA can absolutely have systemic features: nodules, pericarditis, eye involvement, but it does not produce that combination. The oral ulcers are a mucosal expression of the same autoimmune process. When you see malar rash plus oral ulcers, plus arthralgias, plus fatigue, plus a young woman, the mechanism is pointing you to one diagnosis. Your anatomy step got you to autoimmune. Your probability layer got you to SLE. The mechanism sealed it. That's how you answer a most likely question. Not by eliminating wrong answers, by building toward the right one from the data. Now let's talk about pattern 2, which is the workup question. Because building a differential is one thing, knowing which test to order first is another skill entirely, and the AANP tests it constantly in the assess domain. Here's the rule. The first test you order should be the one that most efficiently answers the most important diagnostic question, and that is almost never order everything. It is a single test that either rules in or rules out the diagnosis at the top of your list, depending on which one is more dangerous to miss. Staying with our SLE example, you've built your differential. You're thinking SLE. What do you order first? ANA, anti-nuclear antibody. And here's why. ANA is the highest sensitivity test for SLE, which means it misses very few true cases. A negative ANA in a patient you're evaluating for SLE is a powerful data point. It effectively rules it out. That's the whole point of a sensitive test. You use it to screen. You use it to rule out. But, and this is where students get it wrong, a positive ANA doesn't diagnose SLE. ANA is sensitive but not specific. It can be positive in lupus, but also in Hashimoto's, RA, Sjogren's, and even a percentage of healthy people. So if your ANA comes back positive, your next step is anti-dsDNA and anti-Smith. Those are specific to SLE. You follow a positive screen with a confirmatory test. Sensitive test first to rule out. Specific test second to rule in. That sequence is mechanism driven, and it is the exact logic the AANP is testing when it asks for your initial workup. So when you see a question that says, which of the following is the most appropriate initial diagnostic test for suspected SLE? The answer is ANA. Not anti-dsDNA, not complement levels, not a skin biopsy. Because initial means first in the sequence, and the first test in the sequence is the one that screens. Which brings me to the third pattern, and honestly, this one is just about reading carefully. The AANP is notorious for using specific language that carries specific meaning, and if you're skimming, you will pick the wrong answer even when you know the content. Here's what I mean. The word initial means first in the clinical sequence, not the most important test overall, not the most definitive test, the first one you do. Most appropriate means the action that fits the current clinical evidence and the current guideline standard, not just what sounds clinically reasonable. Most likely means highest probability given this specific picture, not what you see most often in general, but what fits this patient. And next best step is the one that gets students the most because the answer might not be a test at all. It might be a treatment, a referral, a conversation with the patient, the next logical move in the clinical sequence. When you see any of those words in a question stem, slow down, read the stem again. Find the one feature that distinguishes the right answer from the three plausible distractors. That feature is always in there, and it always connects back to mechanism. The ANCC call out. Now let's talk about how ANCC tests the same clinical reasoning, because it approaches differential building from a broader perspective than the AANP. And if you're sitting for the ANCC, you need to know where it adds layers. The ANCC has 4 domains: assessment, diagnosis, clinical management, and professional role. Differential reasoning touches all 4. Here's how. The ANCC evidence layer on differential building. The ANCC does not just test whether you can build a differential. It tests whether your differential is grounded in current evidence-based guidelines and standards of care. That is a critically different question. AANP question asks, what is the most likely diagnosis? An ANCC question might ask, according to current evidence-based guidelines, which of the following is the most appropriate next step in the evaluation of a patient presenting with X symptoms? That second question has 2 parts, the clinical reasoning and the guideline knowledge. You need both to answer it. What does this mean practically? For every major diagnostic category you study, you need to know not just the mechanism of the condition, but the guideline that governs its evaluation. Suspected SLE. We are using the ACR/EULAR 2019 classification criteria. Suspected RA, the 2010 ACR/EULAR classification criteria. Suspected hypothyroidism? We would look at the ATA guidelines, where TSH is the initial test. Chest pain evaluation. We would review ACC/AHA guidelines on chest pain evaluation, including the heart score for risk stratification. The ANCC puts guidelines in the question. The AANP assumes you know the mechanism and will apply it. Both require mechanism knowledge. The ANCC just makes the evidence framework explicit. The ANCC Diagnostic Uncertainty Framework. The ANCC Clinical Management Domain includes something AANP does not test explicitly: therapeutic communication around diagnostic uncertainty. There is a growing body of evidence, including work published in JAMA Network Open in 2023, suggesting that communicating diagnostic uncertainty clearly to patients actually improves clinical outcomes. It keeps the clinician from prematurely closing, it keeps the patient engaged in providing additional information, and it sets appropriate expectations. ANCC tests this as a clinical skill. When your differential is genuinely undifferentiated and you cannot confidently establish a working diagnosis at the end of a first visit, what do you say to the patient? How do you communicate that you are still working through the possibilities without alarming them or undermining trust? The correct ANCC answer always follows the therapeutic communication framework. Be honest about uncertainty. Explain the evaluation plan. Set clear expectations for follow-up and ensure the patient knows when to return sooner. What you never do, and what ANCC tests as a wrong answer, is overstate your confidence in an unconfirmed diagnosis to comfort the patient. That is how premature closure starts. A reassuring statement like, I think this is probably stress, before you've ruled out autoimmune or malignant causes, is not therapeutic. It is dangerous. ANCC knows this. The ANCC professional role layer on diagnosis. Here's the layer that is uniquely ANCC territory. The professional role domain tests your understanding of the ethical and legal obligations that surround the diagnostic process, and it is tested in scenario format, embedded within clinical questions, not as separate professional role abstract knowledge. The most relevant professional role concepts for differential building are these. First, informed consent applies to your diagnostic workup, not just your treatment. When you order a test that has meaningful clinical implications, an ANA panel that could come back positive and change a patient's life, the patient should understand what you're looking for and why. ANCC tests whether you recognize this. Second, diagnostic uncertainty is a clinical documentation obligation. If you have not reached a confirmed diagnosis, your documentation should reflect that. Rule out SLE, or undifferentiated inflammatory arthritis under evaluation, is clinically and legally appropriate. A premature diagnosis label that gets propagated through the chart without diagnostic confirmation is a patient safety issue. An ANCC tests your awareness of this, particularly in multi-provider settings where one NP's working diagnosis becomes the next provider's confirmed diagnosis without the data to support it. Third, The ANCC tests scope boundaries within the diagnostic process. As an FNP, your scope includes diagnosing and managing conditions within your training and competency. When a clinical presentation is genuinely outside your diagnostic expertise, a complex rheumatological presentation, a suspicious neurological finding, a presentation that could be malignancy, the clinically and professionally appropriate action is referral. ANCC tests when you recognize that limit and act on it. Applying the framework. 2 clinical scenarios. Let me walk you through the framework in real time on 2 cases, one straightforward, one not. Case 1, 58-year-old male, sudden onset severe headache, worst headache of my life. Step 1, anatomy. Structures that can produce headache include the intracranial vasculature, the meninges, the brain parenchyma, the eyes, the sinuses, the cervical spine, the scalp musculature, the temporomandibular joint. Step 2, mechanism filter, vascular, subarachnoid hemorrhage, hypertensive emergency, giant cell arteritis, infectious, meningitis, encephalitis, neoplastic, intracranial mass with hemorrhage, autoimmune, CNS vasculitis. Step 3, probability layer, 58-year-old male, sudden onset, severe, worst of his life. That descriptor is a red flag that shoots vascular etiology, specifically subarachnoid hemorrhage, toward the very top. The thunderclap onset is the mechanism telling you a vessel ruptured, blood entered the subarachnoid space. The pressure differential triggered immediate maximal pain. Step 4, can't miss, subarachnoid hemorrhage. This is a can't miss diagnosis. It is potentially fatal within hours. It must be ruled out before any other explanation is entertained. Your next step, non-contrast head CT, not triptans, not pain management, not reassurance, non-contrast CT. And if the CT is negative but your suspicion remains, lumbar puncture for xanthochromia. Because a negative CT does not rule out SAH. It is 95 to 98% sensitive in the first 12 hours, but that sensitivity drops after that window. This is what the boards test, not what is subarachnoid hemorrhage. But given this presentation, what do you do next and why? The mechanism gives you the answer. Case 2, 34-year-old woman, 3 weeks of progressive fatigue, weight gain of 8 pounds, cold intolerance, constipation, and hair loss. Step 1, anatomy, multiple systems involved. This is not a localized symptom. Multi-system symptoms point toward a systemic process, endocrine, autoimmune, or metabolic. Step 2, mechanism filter for systemic processes, metabolic, thyroid dysfunction, adrenal insufficiency, autoimmune, Hashimoto's SLE, anemia of chronic inflammation. Neoplastic, lymphoma can cause B symptoms including fatigue and weight changes, but not this specific constellation. Step 3, probability layer, female, reproductive age, the specific combination of fatigue, weight gain, cold intolerance, constipation, and hair loss. This constellation is mechanistically specific to hypothyroidism, and within that, Hashimoto's thyroiditis as the most common cause in this demographic. Each symptom traces to the same mechanism. Insufficient thyroid hormone leads to reduced metabolic rate, leads to reduced thermogenesis, leads to cold intolerance. Reduced GI motility leads to constipation. Reduced metabolic turnover of cells leads to hair loss. Fluid retention and reduced lipolysis leads to weight gain. Step 4, can't miss. In this presentation, adrenal insufficiency deserves consideration. It can present with profound fatigue and weight changes, and requires different urgent management. The distinguishing features. Adrenal insufficiency more commonly presents with weight loss, hypotension, and hyperpigmentation. This patient's specific weight gain, cold intolerance, and hair loss cluster is far more mechanistically consistent with hypothyroidism. But if your first TSH comes back normal, you revisit. Your workup TSH first. High sensitivity, the most efficient initial test for thyroid dysfunction. If elevated, follow with free T4 to determine severity and distinguish primary from other causes. If Hashimoto's is suspected, add TPO antibodies. Here is what I want you to walk away with. A differential diagnosis is not a list. It has never been a list. It is a structured mechanism-driven reasoning process that starts with anatomy, runs through mechanism, weights by probability, and keeps the dangerous diagnoses in view until the data clears them. Every time, without exception. This framework is what separates providers who practice from memory from providers who practice from understanding. And it is exactly what both the AANP and ANCC are testing when they ask you to synthesize clinical data toward a diagnosis, because that is what independent NP practice actually requires. The boards are not testing whether you know diseases. They are testing whether you can think. And now you have the framework to prove that you can. Research on diagnostic error makes one thing abundantly clear. Cognitive errors, including anchoring and premature closure, are present in the majority of diagnostic mistakes. The antidote is not more memorization. The antidote is a structured process that forces you to consider the full differential and explicitly rule out what matters most before committing to a working diagnosis. That process is what you just learned. For this week's homework, and yes, I always give homework, I want you to take one clinical case you've seen recently or one practice AANP question you've done and walk it through all 4 steps out loud. Not in your head, out loud. Anatomy first, mechanism filter, probability layer, can't miss filter. The act of verbalizing the framework is what encodes it. You are building a reasoning habit, not reviewing information. Think like a provider. Build the differential. Derive the answer. Your patients are counting on it. I'll see you next week.